Good job, and thank you very much, Doug. Let me start the questioning, watching my colleagues tense. Louis, let me again come back to this theme of how do we take the immediate and long-term post-disaster preparations and build towards an idealized vision of a healthiest possible environment, in this case having the most adequate clinical delivery system. I wonder if you have any thoughts, as you described protecting hospitals during the crisis and the interrelationships between hospitals and this notion of a universal health care system. Do you see any benefits from the Affordable Care Act and the private sector efforts to create these accountable care organizations, these patient-centered medical homes, which restructure the relationships between the ambulatory system and the hospitals and the ERs so as to theoretically, at their best, find a more of an integrated relationship built upon shared data, shared relationships with hospitalists and so forth and so on. Do those trends offer something that can be enhanced because of the response to crisis, which generates an even more intense, volatile relationship that pushes people and organizations together?
Well, certainly, it's a great step forward. A patient-centered approach would guarantee the care during an event and then after, and to try to integrate it in a very functional fashion. But I think the issue really is when you give the hospitals that go down, that succumb to the storm, a buy, who's doing their task. In other words, they said we can't function, and they allocated that responsibility elsewhere. So it may be that a hospital has to go down, but there has to be a way to supplement that responsibility. It might be that hospital's responsibility for a large population in the outpatient department, in the primary care services, and following up for surgical procedures, but they said we can't function, so we sent our clinic out to Elmhurst, or we sent our clinic of following people to the North Bronx. And the guy who wants to come in and get care, the woman who needs follow-up, just delivered a baby, doesn't have a continuity system when it's lost. So the question is that I think if there certainly are places to reestablish the care system in a marginal way, in a local environment, and then to have at least those people who are, let's say, involved in that affordable care, patient-centered system, that you would follow people more carefully, that you can't abandon. And there has to be enough support for that. And the way you pull it together the way we've got it set up is, the VA's got to do one thing, and the Health and Hospital Corporation's got to do another, and the private system's doing something else, and they're not in any way integrated, so you've got probably 3 systems you got to set up if you lose those 3 places. So it doesn't solve my problem. It enhances the foundation for most people to do good and allows you to set up a replica in some makeshift urgent care area.
Is there a way then that we can use the necessity of creating fluid movement of people across settings of care, knowing that you've got some hospitals that are down, some things are, so there has to be I don't want to put words in your mouth, but I'm trying to think of a way in which you have identification of patients, identification of providers, common information systems that allow you to track people. The patient has their medical records that are already clearly identified. They can go with them or accessible somewhere, since they'll have lost them in the flood, but there's a way to connect those through. And that there are relationships between the provider groups, the ambulatory and the hospitals, that will meet the plan, that can be planned for preemptively to meet the needs of the emergency system, but that because it exists, mirrors the idealized state of a functioning, patient-centered, holistic, integrated clinical delivery system? Can we take it and use either the crisis, the planning post-crisis, or the pre-planning efforts to fast forward us to the idealized state?
I think absolutely. I sense the first thing I try to suggest is that you lose your hospital, so you've got an armory. You put your system up there and you bring your teams and you achieve maintenance for the people on a continuing basis. And you might, if you want to separate, let's say, how a veteran gets it and how a private practice person gets it. There weren't places that were functioning. Someone had to bring in the power. So you set it up in a big space and you really start to do it again. There are lots of providers. This is the basic care. You might have to take trauma some long distance. You take something else a long distance. But essentially the fundamentals of a healthcare system should be preserved no matter what happens.
Right.
And this is the foundation.
If you wouldn't mind offline, again, with our crack team of people that will work with you, to just so, and then we'll get you, Dan, for sure. We might want to ask you to give us some suggestions as to what might be the things on your PERC chart list that we need to have to solve your problem that help us to get to the idealized state.
Just a comment.
Erwin, why don't you come to the mic here?
Just want to make a comment about the question you just asked and Lewis's response. During the H1N1 situation a few years ago, I actually was called by literally the CEO of a very large hospital system in New York, and the question was, would you allow us to deploy a couple of your mobile medical units, which we have quite a number of, in the ambulance bays of our hospital because the ER was getting overwhelmed. And this happened to be a hospital system with an enormous ambulatory network. I mean, enormous. And we weren't able to do that at that point because those units were being used. But my point to that hospital, and it relates to what's developing now even more strongly with the ACOs, et cetera, is that the planning for disasters should fully include and embrace the ambulatory networks of these systems from the planning phase forward, so that you're not scrambling when the thing happens to figure out how to defuse your emergency room, that everybody, including the private practices, the ambulatory centers, the specialty clinics, et cetera, all know what they will do if called into action. They've been trained, they've been retrained, and there are systems and protocols in place to just green light that and let it roll out when it's needed. That's yeah.
Thank you.
know,
Thank
just
you. Why don't you stay there, because I'm going to pull you in.
follow up on the point that as soon as the storm hit New York, my compatriots in New Orleans called and said, you see, the charity still could have functioned. As soon as that storm brought it down, you better make sure you get your hospitals open. It could be a good test whether you can decrease 1,000 or 1,500 beds in New York City and see how people function. And so the paranoia or the truth, in a sense, why not have it functioning as soon as possible? Because the community needed it and the people were there to do it. And so you have to build that in, and you're exactly correct in designing it as you
Daniel?
For Betty and Doug, I wonder if you can talk just briefly about the evidence out there on the role of social cohesion in mitigating the effects you're discussing in children, anxiety, depression, and PTSD.
Well, this is Betty. I would say that a number of the child disaster mental health interventions have modules or content and activities focusing on social cohesion. So clearly, providers think it's an important aspect of intervention for children and families. Its specific effects have not been studied, however.
Yeah, this is Doug. Yeah, those modules do exist for both psychological first aid and SPR. I can also tell you by venue, it's represented in the work that you saw in Joplin with the social cohesiveness in the potluck dinners that we served. We also found it in other areas, areas that people tend to gather. So you can look at an environment. Suffolk County, their libraries were used post-Sandy as launching places for these types of interventions, again highlighting the need for people to gather and be together in times of need.
Let me ask Erwin if he would weigh in with both Betty and Scott, a little bit, and Doug. I mean, this notion of the vulnerable child. Erwin, you have, if I know anything about your work, it is, I'll use this word, you wouldn't, but an enormous frustration that the child mental health needs in a crisis, in a disaster, are, both not only the short term, but the intermediate and long term, are not adequately addressed. And I guess the question is, it comes back to, what is it like to have the conversation with the powers that be who are planning the response to a disaster? The political infrastructure, the planning infrastructure, those people that are in charge, and you try to make the message that you've got to attend to the psychological needs, given the caveat that Betty and Daniel just went through around, needing to make sure that, above all, we do no harm in the intervention, which I think is underlying a lot of that you make sure that these interventions, sometimes you might make it worse if you're not careful. But at the end of the day, what's it like having the conversation with them? Is there in any way an openness to addressing this as a priority?
Well, that's an interesting way to put it, Reed, and I much rather would be asking the question than answering the question. So the problem is that child mental health services, for instance, to take that thing, is entirely inadequate, especially for underserved communities right now in the, before we ever get to a disaster. So the pressure on officials to create systems to respond in the aftermath of a disaster is enormous. And most of the people that I speak to, I must say, unofficially are equally as frustrated as I am and other providers are. And hands are tied. There's not enough providers. They're not organized. There's not enough money, et cetera, which actually brings up a question I wanted to ask Doug and Betty, actually, too. But the first question for either, especially Doug, is the programs that you have deployed in terms of scale. What do you know about the denominator issue? What percentage of the need is being served by the kind of programs you're talking about? And are those programs scalable? In other words, are you meeting 5% or 95% of the need that's out there? And if it's anything less than 90%, let's say, what is it that we have to do to make this a full package? So it's not just a good example of a demonstration project, but something that actually could be used universally in the aftermath of a disaster to make sure that all children are getting equal access to the services that might be very helpful to them. If I could just start with that.
That's a good question. I can't answer that directly. I know that if we were to meet up with Suzanne Smith, was leading our charge around Hurricane Sandy. That's the largest, at least crisis counseling rollout of SPR that's ever been done, and the scale really caught us off guard as far as training. It's difficult to say, what that proportion would be. Obviously, finding kids in schools is the best way to canvass a community, knowing that you're going to catch most, say, in that case, children. The workplace is another, if people have work, finding help for them there. So I can't answer that directly, but I know that we're getting better at it. But there's a lot of frustrations around territory, people not being as cooperative, especially around schools. When you work with schools, it's not a given. There's a lot of politics and relationship building that has to happen before entering a school. And as a school principal, looking outward, I would be really hesitant to let any Joe Sixpack come in to my school to do work. So I think there's a lot of relationship building, in this case around schools, that can be done maybe through some national organizations to get them prepared on who to talk to and who to interface with. And I think that would help give your best bang for your buck and making sure that kids' needs are met.
So this might suggest for the IOM, for instance, as kind of further research that needs to be done. It's not only about can you create a model program that shows proven effectiveness and impact, but what are the strategies that will work best to make sure that those programs go to scale?
And I would add, this is Betty, I would add that it's critically important that those programs that are delivered universal populations in, for example, schools, include mechanisms to identify the children who need something more than public health interventions, the children for whom the impact is so great that they need clinical services.
Thank you. Ciro and then Linda.
Thank you. Health services are so important during emergencies that we cannot afford having them.
Use your mic.
Yes.
Oh, yeah, closer. Thanks.
Okay.
I want to hear every word.
We need to ensure, thank you. We need to ensure that health services, particularly hospital, but also all of the health services, remain operational in emergencies. So my question is for Scott and Lewis. How do you assess the probability of the health facilities, in this case of hospitals or clinics, to remain operational in times of emergencies? And how do you plan for rapid recovery in case they don't?
The issue of planning, I think that the planning historically, building a hospital where it is a problem. So that, for example, Bellevue Hospital used to be in the middle of the East River 100 years ago or 120 years ago. So it was not something that they'd ever had a storm that sunk it before. So now all the hospitals are rebuilt with FEMA analysis such that there's going to be a 17-foot seawall around the hospitals. None of the electrical systems are going to be below the ground floor, or lots of it at the third floor in the hospitals. You know, they're changed. They gave up the bottom floors. The Veterans Administration Hospital, they gutted a good part of the University Hospital. They eliminated everything from the basement at Bellevue. So they expect the hospital, the sense we were told is that you have to rebuild the hospital. And they invested a lot of money, the federal government, in looking at what would assure that the hospital would be good for its future lifespan. They don't expect anybody to evacuate. Evacuation wasn't discussed, but it was a terribly difficult and complex problem, and it was an abandonment of the community that everybody recognized. So they expect those hospitals not to go down ever again. If they go down again, presumably can't be rebuilt there. I mean, I think that was the theme of the discussion throughout.
It's Scott. I definitely have to agree with you. You know, it's all about lessons learned, and you need to learn your lesson. And especially when it comes to federal dollars, they're not going to, expect it to happen twice, so to speak. Even though there are those failures that occur, they don't want the same thing to happen twice. So I would have to agree that when we learn of something, we need to address it. And when it comes to hospitals today, really in general, they don't expect to ever have to evacuate. Unfortunately, hospitals both in New York and in New Jersey, they had multiple failures for multiple reasons. Not necessarily always water, but just failures in electrical service and so forth, and generators, et cetera, which again, I'm assuming are going to be addressed, and hopefully, while anything can happen, it'll be minimized for future disasters. But really, you can plan. Something's going to happen, and the idea here really is to have a lesson learned and to make the appropriate changes. Today, like the doctor said, there should be no reason to have to evacuate a hospital, with the exception of very, very few circumstances.
Thank you. We have Linda, Bopper, and Elisa.
So I wonder if you all could speak to the fact that there are so many different provider systems that are dealing in a community that really don't often collaborate in the best of times. So do you have any examples of good public and private partnerships that have worked in the case of a disaster, and what enabled those kinds of partnerships to be effective?
Well, I'm not sure there's a fair answer to the second part of the question. The first, if you don't believe as a city or a state or a country that every person is entitled to care every single day, then you're leaving a large part of the population uncared for a good part of the time, 99% of the time. My hope would be that during a disaster we could respond indiscriminately to all people and do the best. This last experience led me to believe that we can't do that either. So one would say that in your city, conceivably, people waited an awful lot longer to get into the charity emergency department than at Bellevue. We worked very hard for that. We thought we were well prepared for things. We didn't have enough system to withstand the storm. So that if you don't include, we talked in all of our work on preparedness since the bombing of the World Trade Center before, that if you can't let someone have TB in the city of New York, it's unacceptable because the community will get it. If any person is uncared for, the city or the country is unsafe. And so that creating a universal healthcare system seems essential, and it's illusory to believe that if you don't do it every day, you can do it in a disaster. The people who are the most fragile, most vulnerable, most disenfranchised are the ones who everyone's already forgotten. So when you're worrying about surviving yourself, you're not going to do well for those other people in a storm.
One of the things that we realized during Hurricane Sandy is that, and again, it's nothing I don't think necessarily new to New Jersey, but we have these master plans. They're both federal, state, and on down. And one thing that we really learned is that as great as your plan may be, when it comes to resource allocation, if you're a little guy or you have the quietest voice during the disaster, you aren't necessarily going to get the attention you need. And we found that out a lot. And while those people may have needed it more than others, just because of the way that they were perceived or the way that they came across, they suffered. And what came out as a result of that is a lot of local, and when I say local, I'm talking more on a county basis, partnerships that are formed, that private-public partnership that you're talking about. For instance, Monarch, again, we're a nonprofit, but we are a private company, partnering up with the actual county, for instance, Monmouth County, which is one of the central counties on the shore. And, basically they were not necessarily seeing what they, or getting what they necessarily needed during the storm or post-storm. And we quickly partnered up and were able to solve the problem a lot faster and more efficiently than if we were waiting for big government to do it. And again, I know there's some inherent problems with that sometimes where resources start getting shifted and it's not necessarily abiding by quote unquote master plan, but it became a necessity, and then it became something that really worked out well. And as a result of that, we have plans in place for future disasters, whether it be a major storm where there's no power for weeks, followed by snowstorm, followed by whatever, or something on a shorter duration basis. But again, it's not anything that's startling to anybody in this group. But I think that how you solve a lot of these things is a strong partnership. And I'm not saying go rogue and don't pull yourself out of the master plans, but have those contingencies in place.
Great. Let me move to Bopper and then Elisa.
A great panel. Thank you very much. Let me, from my own experience in the Department of Veterans Affairs in Katrina, Rita, and other times, I would observe that the actual inpatient, even clinical, hands-on clinical needs of patients during disaster and post-disaster is probably 5% of the need. And so from all of your perspectives on the panel, I would be very interested to get your perspective on what are the possible applications for optimal recovery. I'm out of the immediate disaster mode, but in terms of community recovery for applications of telemedicine, virtual health, connectivity, social media. I would observe that probably everybody in this room is too old to understand how the younger generation will be using social media for their health care. So, this book that we're going to produce, these recommendations are really for the future. So how are we going to use the amazing advances of technology in telemedicine and virtual health for communities to be resilient, to be able to, after their response, in fact, recover in a durable way. So I'd love to have some perspective on that.
Yeah, this is Doug in New Orleans. I have thoughts about the telehealth, telepsychiatry aspects. We've done some here post BP oil spill down with Home Indian Nation, and I think that model is a good one. But I think it has to be formed in a consultative model, not providing direct care. Whereas, say, a mental health professional in New York State consult to a nurse practitioner in Louisiana at a primary care setting, and in a lot of ways increase capacity by serving 6, 10, 12 kids who have behavioral health or mental health types of issues, rather than a one-on-one relationship. So, in regards to telemedicine, I think a consultative model would be embraced. As far as social media, or at least technology, I think that in the next 5 to 10 years, we're going to see programming in real time, people be able to report up their mental health functioning through mobile phone apps. And that we've had some discussions at the National Center in trying to develop apps where people in real time could measure their functioning, and we could have in a few years a real pulse on a community given this type of technology.
Terrific. Thank you. Let me go to Elisa, and then we'll do you, Robert.
If I could say just one response.
Oh, yeah. Thanks,
So
Louis.
the Poison Center of the City of New York, health department effort, the call volume increased dramatically during the storm. That was a phone call you could get through. And so people called about their gasoline siphoning problems and their risk of concerns of carbon monoxide. So that's a great way to do it, and to create an open access system that you don't have to have a poisoning, that you just have to have a problem. I think the Denver group has set that up for some time through Denver Health, but that would help us immensely. We don't. The penetrance we have for the New York City Poison Center, with the tremendous effort in Mandarin and Cantonese and with Spanish, doesn't do well in getting people to call of different languages and cultures. So more than 50% of our patients are all sorts of other cultures. So I don't know that telemedicine is going to help that. Or telephone hasn't worked for us at this stage. Now, maybe the younger people are going to call about things they haven't even talked about. But the other thing we had is we had the pediatric psychiatry team from the emergency department was available 24 hours a day there talking to people, as was the adult once we could get open. So we did a lot of talking, and so that was an important outreach system.
One of our taskings as a committee has been to explore the fiscal resources and also some of the challenges in terms of spending those resources. I'm specifically interested in, with regard to the vulnerable pediatric population and behavioral health, if there were specific funding resources available, or if there are, how they're used, what the challenges are in using them, and then also how were the programs tied into non-monetary resources like faith-based or other community-based organizations?
Anybody want to get into this?
I'll go. This is Doug out of New Orleans. I can go back in time. Looking at our clinic side, we lost our office in Metairie, and we're not able to reopen until January. And we're talking the traditional mental health. The need was there, but we were treating mostly the kids that we were treating before. Again, highlighting the fact that most kids do pretty well if supported through these types of resiliency programs, or just being back in school. I remember that there was no financial support for our clinic side, just traditional mental health at the time. We had to go it our own, except for the Red Cross had a voucher program. I think they were offering up $2,000 for mental health to be received anywhere. I think later on we received the balance of that money. It was unspent, and so we received that grant to provide free services in the New Orleans area. So we're a faith-based nonprofit, and so we were able to work with Red Cross to meet those ends. But other than that, we lost like 6,000 allied health professionals, a lot of them mental health, and so there was it took about a year and a half for everyone else to come online. And part of it might have been around the fact of getting people back in their seats, so to speak. as psychologists or social workers or psychiatrists.
Great. Anybody else? Great. All right. And last one before the break is Robert.
So I'm hearing a tension here between Dr. Goldfrank's call for a universal system with the recognition that we don't have one, and when contingency plans are in place, be it in Monmouth or in New Orleans or in Oklahoma, not what really seems to pull through and save the day for a lot of people are the self-organizing systems. And as we move forward and look to investments, is it the self-organizing systems we ought to be focusing on? Is it creating a web of those we ought to be focusing on? I heard loudly the sort of, I think it was Dr. Walker who said, you know, but it's the loud voices that got heard the most. And as the social media starts to play a bigger role, if we focus on the self-organizing systems, will it be different loud voices that get heard the most? And so I'm just wondering, and to explore that sort of tension in there a little bit.
I don't know, it's the tension, it's the facts, that we have a system that isn't designed to care for all the people, and we have such differences in the quality that it creates tremendous disparities. And there is, I forgot to answer your question, there's a public-private collaboration that's very consequential, let's say, in the city of New York, but it creates, it helps each private system helps the public and the public helps the private, but it doesn't cover the most disenfranchised. It doesn't have the resiliency of a system to deal with it, and that the big vision that we would all be doing much better if we have a system for all people isn't bought by large numbers of individuals. And you know that the things that we need to modify are very creative. It's not, you can do all sorts of creative things for a few people and reach some needs, but you know, you have special human beings, the kind of people I tried to describe. We had psychiatric patients who were poorly compensated, who came to the door every single day till the place opened. Though no one wants to care for that person. We talked about whether they're adults or children, the very needy. They're people who are hard to get to, and who you say they're chronic inebriates, or they're chronic people who are not fitting into the system. Well, everyone's shown that you can find a way for the most conservative and liberal, progressive or reactionary to work together. If you say, I can do a humanistic job of care for that patient by getting a navigator for him to get him or her back to the system, and you can tell the guy who doesn't want to typically invest, so we're going to save a lot of money for society if we do this, if we transform the mechanisms to reach out to everyone and put it together. And so I think and that's what some of the Accountable Care Act is going to work on, some of these issues, but it doesn't deal with all the people now. That is, I think, the only way to come up with a real system that we could be proud of.
Anybody else want to respond? Great. All right, well, with that, let me just thank the panel. Excellent, excellent work. Thank all of you that were on by phone and the effort that you took. I think all of us, a lot of us have had a recent opportunity to know the anxiety level that accompanies trying to get to a speech or a presentation and you can't get there and you basically freak out. So please reduce your anxiety level and know that your efforts on the phone today more than met the challenge of the committee, and thank you for all of your time. And we'll talk to you guys later. We're going to take a brief break. That break will, which was originally going to be until 11:20. And so we basically will reconvene at, let's see, what time is lunch? 12:45? So why don't we reconvene at, this will be odd, but we're going to reconvene at 5 minutes of. Now, you know I start at 5 of, so don't mess around.